Acute grief leads to disruption of biological rhythms, impaired immune functioning, decreased lymphocyte proliferation, and impaired functioning of the natural killer cells. The phenomenology of grief, bereavement involves a variety of coping strategies. It can lead to alterations in interpersonal relationships, self-esteem, worldview, and these changes can last indefinitely. Manifestations of grief that depends on the personality of the person, previous life experiences, past psychological history, relationship with the deceased person, and an existing social network. Now, bereavement includes three overlapping phases: initial shock and denial, intermediate period of acute anguish, and culminating period of reorganization. Now, shock and denial can last for minutes, days, or weeks, characterized by disbelief, numbness, searching behaviors, and protest. Acute anguish, weeks or months, characterized by somatic distress and withdrawal, anger and guilt, and lost patterns of conduct, including restlessness and agitation. In resolution, months to years, patients have finally grieved, return to work, re-experience pleasure, and seek companionship with others. Now, bereavement during special age groups like childhood and adolescence. Most common in childhood is losing one or both the parents, and sibling death is second most common. The grief reaction is colored by the developmental levels of the child, may not resemble adult reactions, may display minimal grief, may experience the full effect of grief later in their lives. Children might not withdraw, instead they may throw into activities, and they may experience indifference, anger, or misbehavior, may not display sadness, and the behaviors can be erratic and may show grief only occasionally. They may often play death games as a way of working out their feelings. In reality, children's grief lasts much longer than that of adults. Mourning in children needs to be addressed in all developmental stages, and children will think about the grief at various stages of their life, like graduating from school, when they're getting married, when they're giving birth to their own children. The older children frequently feel abandoned when the parent dies, and they may also show hostility towards the surviving parent because they think that a surviving parent can also abandon them. Children more than 2 years may show a loss of speech. In school-going children, phobia, withdrawal, poor academic performance, and peer relations suffer. Adolescents may experience behavioral problems, somatic problems, erratic moods. Adolescent boys may become delinquent, and adolescent girls may turn into sexual pattern for comfort. Now, bereavement during adulthood, the most stressful life events are death of a child and death of a spouse. The child's death is a life-altering event. Death of parents and siblings in adult life, they're relatively milder as compared to loss of a child or spouse. Grief is most intense for mother in the late perinatal losses like stillbirth and neonatal death. Sudden infant death syndrome or the cot deaths. Here the death is sudden and unexpected. Here the parents often blame each other, and it leads to marital discords. Now, acute immunodeficiency syndrome and bereavement. So surviving family members, friends, or partners of individuals who have died from AIDS are uniquely challenged because AIDS carries the stigma, and caregivers, they also fear of contacting the illness. Often HIV-infected people and caregivers have death wishes. Elderly and bereavement, they face more losses in other stages of life, leading to intense loneliness. For highly impaired elders who lose spouse on which they're dependent for daily functions, the bereavement reactions here are most profound. Treatment in normal griefs, people seldom seek any psychiatric help. Professional assistance is needed if there is markedly divergent reaction or like a suicidal attempt. Bereaved, they have to go through mourning process for successful resolution to occur. Pharmacotherapy, a mild sedative can be given to induce sleep, or antidepressant or anti-anxiety drugs may be given as per case to case. There's something called psychotherapy, grief therapy. Here, regularly scheduled sessions should be given. The bereaved is encouraged to talk about the feelings of loss. He or she should be reassured that having ambivalent feelings about the disease are completely normal. And this therapy can be conducted as a group therapy. The self-help groups, they are much beneficial because they provide social and emotional support by offering companionship for the bereaved. Now we also talk about the life events. So life events are sudden changes, positive or negative, which disrupt the normal course of an individual's social life. The life event scales are the scales used for assessment of exposure to these stressors. One is the Holmes Rahe stress inventory, and other is the presumptive stressful life event scale. The Holmes Rahe stress inventory, Thomas Holmes and Richard Rahe, they gave a 43-item self-assessment scale. The maximum score was given for the death of the spouse, that is 100. Even marriage is given a score of 50. So even marriage is a big stressor for a person. Even going to a vacation is given a score of 30. A minor violation of law is given a score of 11, which is the lowest score. The American Institute of Stress regards the score of 300 or more as 80% chance of health breakdown in the next 2 years. So this is a snapshot of the Holmes and Rahe scale. We see here death of the spouse is given a score of 100. Marriage is given a score of 50 here. And the lowest score is minor violation of law, giving a score of 11. Now, the presumptive stressful life event scale, PSLES, it was given by Gurmeet Singh. Now, this is an Indian adaptation of this Holmes Rahe stress inventory. It's a 51-item scale. Here, the maximum score is again death of spouse, which is given a score of 95. Marriage, a score of 43. And the lowest score is vacation, a score of 20. So this is a snapshot. The highest score is death of spouse, that is 95. There are other scores also. Getting married or engaged, 43. And the lowest score is going on a pleasure trip or pilgrimage. Now we also talk about the bereavement and the psychological distress during COVID pandemic. Psychological distress intensified in individuals who lost close ones due to COVID-19. Psychological distress intensified in individuals who already have a pre-existing psychiatric disorder prior to COVID-19. The increase in symptoms of anxiety, depression, phobia, paranoia, hostility, obsessive compulsive disorder, and psychotism was also seen in the COVID-19 pandemic. These are my references. Thank you.
Any questions? Clarification? Interns? Dr. Sameer? Any questions? Did you understand anything?
Yeah. We have missed only one part. Another thing you have covered in every content. Bereavement in oncology. So there is a palliative care. There are patients also have bereavement in many related to pancreatic cancer, oral cancer, whatever it is. They have not covered in that area. Otherwise, it is a wonderful presentation. I asked my father, he has also, he died last 6 weeks before. He had also bereavement last time. He cried to me, in front of me, whenever he speaks to me. He always thinking about God. रात को 2 बजे उठाता है, पावन से बात करता है.
So bereavement in cancer patients is little different because it's such a slow process. The family members are ready that inevitably the end will come. So is it some different stages of grief put together?
Yes, sir. Oncology patients.
Oncology, probably the cycle will be little different because unless there is sudden deterioration. Something.
Premature grief maybe there because you already know, and there are mixed feelings. Like in terminal illness, you never know how long he will survive.
They're different. At times, family members are more prepared.
We need to do individual therapy to the patients also as well as family therapy. Also, they expected more from us.
Maybe we can have debate also, sir. Euthanasia, an extension to it. For and against, typically, right? Any questions? Because this is a very important topic. When Dr. Priya was discussing how to frame it, so I was very clear that let us understand what is grief, bereavement, depression, complicated grief, complicated bereavement. So have you got the concept or you want some clarifications? We can do it. Okay. You all understood everything? How you differentiate then depression from bereavement?
This may be important because earlier on, the psychodynamic part, depression was plus, like you may find, I don't know the current textbook what is it, but you may find depression, being associated with loss of a close one, like bereavement also. That loss is described as depression earlier on. That is different from what you're saying. So that difference needs to be, especially to the undergraduates.
Yes, that is why it is important. Have you understood what is depression, what is grief? What is the difference between both of them? There is a discussion.
Impairment and depression.
There is no functional impairment in grief.
If you talk about bereavement,
Self-esteem is preserved in bereavement.
so bereavement, all the themes will be regarding the bereavement, the loss.
Childhood,
Self-esteem generally will be preserved. When we talk to the person, we'll still feel that there will be the mood reactivity present in bereaved. When we take the discussion away from the deceased, in depression, it will be difficult to actually has his mood little reactive. As she said, functional impairment will be transient, mild, not to the degree of where major depressive disorder is there. Right.
Persistent feelings.
Persistent feelings around the loss will be there in the bereavement. Yes.
Hopelessness, helplessness, worthlessness.
So if hopelessness, helplessness is there, or worthlessness is there, then these are depressive cognitions. So depression will move towards depression. But if these are only surrounded by the loss and subsequent reaction to the loss, that I'm not feeling bad about myself because I couldn't do anything to save the loss, maybe then it will come as a part of bereavement.
many
So when in bereavement we say that the depression has set in, we are following a patient who has just had a loss for last 2 weeks and has come to us, we would say no, now we need to interfere. It is not a normal bereavement, it is a depression or syndromal depression. So first psychosis, suicidality, psychomotor retardation, patient almost going into a phase of catatonia, and then as per the DSM, worthlessness would set in. So these 4 pointers are there. Now, ये rider था DSM-4 में, where the DSM-4 said that you accept if you find all these, you will go to depression. Otherwise, you will not diagnose depression within 2 months of bereavement. This was removed from DSM-5. That is what the concept is. They said that depression during bereavement and depression after bereavement. That is a 2 months criteria. The course, outcome, treatment, and the prognosis, everything was same. So that is why they thought that no, if syndromal depression is there, we will diagnose it despite irrespective of any duration criteria, within 2 months or after 2 months. So that is what the concept is. And DSM was criticized after homosexuality. The biggest critical point of DSM-5 was this bereavement. They said that they are making bereavement as a psychiatric diagnosis. Because the media said it, and it came into social media and it was criticized a lot. So in that context, this presentation becomes very important. And then she mentioned it. Actually, uncomplicated bereavement is not a mental disorder, but media inflated this concept of that. Then something has come up like complicated, the persistent and complicated bereavement disorder or complicated grief. So these are the pathological variants when grief doesn't. So very easy to remember if the person is still preoccupied with the loss of the first anniversary continuously, then it is a complicated, persistent complicated disorder or grief disorder. So that is a little easy to, and then all those criteria should be fulfilled. One point I saw there is that the bereavement person would block positive feelings. That actually works with patients when we talk to them. We do a grief counseling at our own level. We tell them, please don't block your personal memories, positive memories. Enhance the positive memories, block the negative memories. It might, make things better for you. Any questions?
as per psychosocial view, there is a lot of bereavement patients that's not identified. They were living in old age homes, such as other homes, because of their separation from their spouse, after 60 years, everybody needed psychiatric investigation. That, but nobody does it culturally and ethnicity based.
As per DSM-5, we will diagnose depression if we find the person fulfills the criteria. Whether it is specified bereavement or grief or loss or not. So what's the difference between grief and bereavement? Grief is a feeling. Bereavement is a state. The person is going through, is bereaved, or the person is having bereavement. Okay, so we have to actually have introduction today. All right. So please, first, please can you come and introduce yourself?